So we're going to move on to our next speaker now. That's Anna Maria Deganello, who's a paediatric radiologist from King's College Hospital in London, who's an expert on not only paediatric hepatology imaging, but also on paediatric trauma. And Anna Maria is going to be talking to us about the use of contrast-enhanced ultrasound in paediatric trauma. So over to you, Anna Maria.
Thank you. Thank you very much, Paul. Thank you for your kind introduction. It is my pleasure to be here today and to have a chance to show you our experience on pediatric CEUS in the context of trauma. During the course of this brief lecture, we're gonna focus on a few points. First of all, I want to talk about how useful it is CEUS in the context of pediatric trauma, and I'd like you to be able to, at the end of this presentation, to be familiar with the most common CEUS findings in the setting of trauma, sorry, having a bit of a hiccup. And talking of peds trauma, we have to remember that it is still the leading cause of childhood mortality in children aged between 1 and 17 years of age. But vast majority of these deaths are due to severe head injury. But if you take these patients away from the cohort, still between 85 and 90% of patients who present to the pediatric accident and emergency unit, they're still managed conservatively. So what are the indications for imaging in these patients? Well, of course, if there is any abdominal tenderness of distension, if they present with abrasions or contusions, in any case of gross hematuria or microscopic hematuria as well. Every case of suspected bleeding, obviously, we need imaging, and any case where the mechanism of injury is high risk requires an imaging investigation. But having said all of these, CT remains the main imaging modality to investigate these children. But obviously CT, despite it being the gold standard, still comes with the disadvantages that we all know. So it tends to be performed in children who have to be hemodynamically stable, and it does allow the rapid triage and reduces morbidity and mortality. However, you need to have a cooperative patient, which means very often for a child that needs to be sedated, it has to be stable and transportable. And obviously there is always the implication of relatively high doses of iodine contrast that has to be injected, and ultimately, but very importantly, as Casa mentioned in his presentation, you have to always remember that we are irradiating these children, and this carries a higher risk of developing cancer in the future. So there is a need for some imaging modality as an alternative to CT for imaging these children. So if you look at fast scans, they're not very good, really. So this is a review of some of the literature that's available for the past 10 years or so. And if you look at the values of sensitivity here, they're relatively low. So fast scan, we know, is not very good to detect intra-abdominal injuries. And you mustn't forget also when examining these children that a large number of children even with a significant traumatic injury, they may well present without any free fluid. So that has to be taken into consideration. And even in the most experienced hands, a baseline ultrasound, a classic B-mode ultrasound, may not be good enough to pick up solid organ injuries. And that's because they may not be apparent at all on the B-mode scan. And they often do appear isoechoic compared to the normal parenchyma. So that's where CEUS comes into the picture. And we're very lucky in that the EFSAM has produced some guidelines. And here is the most recent update from 2017, where we looked at non-hepatic applications for contrast-enhanced ultrasound, and that includes the application for trauma. This is not specifically related for pediatrics, but includes them as well. And there are recommendations that came out of the guidelines that can guide you in the use of CEUS in the context of trauma. So when to use it? Well, if the patient is hemodynamically stable with isolated moderate energy abdominal traumas as an alternative to CT, and it's mentioned specifically in children in the recommendation. You can also use it to further evaluate uncertain CT findings. And importantly, the third and last recommendation is to use it as a particularly helpful tool in the follow-up of these traumatic lesions in children. And the advantages of CEUS are just the same as ultrasound. It's very child-friendly, there's no radiation, is available on the bedside, and is also cost-effective. So CEUS is now very well established, especially in European Centre for its use in the setting of trauma. And if you look at the literature, the performance values reported are really close to those of CT, and you can really achieve an accurate definition of the size and limits of the injuries, whether there's extension to the capsule or not, and whether or not there is a presence of vascular injury. And this is a very important point, because some of you, or Lumason in the state, being a purely intravascular agent, it means that if you see bubbles outside the perfused organ, they've got to be from extravasation. So you can be quite sure also about the presence or not of active hemorrhage, ongoing hemorrhage. So this can really guide you in the decision making, whether to send the patient to surgery versus conservative management. And as I mentioned in the literature, there is quite an increasing number of papers. This is one of the first ones from Valentino in Trieste, a few years ago, some 10, 12 years ago, where he looked at the series of 27 patients, and he came up with a couple of conclusions showing that definitely CEUS had a higher value compared to B-mode ultrasound in the detection of solid organ injury, and at the same time, CEUS had performance values close of those of CT. But since then, more papers have come up. This is one of the most recent ones from Vittorio Miele in Florence, where they looked at 73 children, and now their way of using CEUS is that any child that comes through the ED door with a blunt abdominal trauma, they will get a CEUS scan first, and if negative, they will be sent home and called back for follow-up. If it is positive, then they may go ahead and have a CT for further clarification. So it is really widespread. But let's move on to see a couple of examples. This is a child of 7 years of age who had an RTA, and you can see in this contrast enhanced ultrasound, you've got the split mode with the B mode next to the contrast enhanced image, and you can see how you could probably see some heterogeneous parenchyma on the B mode, but the injury is much better defined following administration of contrast. And once you've seen the injury, you can actually move on from the dual screen, and you can concentrate on the injured organ to have a more panoramic view. This is a 16-year-old who had a fall from a bicycle, and this was a CT presentation with a splenic laceration and a large perisplenic hematoma. And I'm showing you these partly to warn you, because we've done this CEUS as part of his follow-up examination, but this was performed slightly early, a little bit too early. Don't forget that these follow-up examinations are best performed after day 5 of injury, and in the spleen we tend to perform them around day 7 or 10 of injury. And the reason is because that's when they most likely will develop a pseudoaneurysm. In fact, in this case, you can see the arteries pretty well, and there wasn't any pseudoaneurysm, and you could delineate the fracture plane really easily, as well as the perisplenic and subcapsular hematoma. But we couldn't identify any vascular injury as such. However, a few days down the line, the patient got discharged, and this was performed a bit too early because of a shortage of beds. And the child came back after sneezing. He had a massive bleed, and this is shown as an active hemorrhage, as you can see here on the CT, which was then demonstrated on the angiogram, and this needed to be embolized later on. So be careful not to perform your contrast and ultrasound follow-up trauma too soon. This is another example of a 2-year-old who was hit by a car, and this was the CT presentation showing a large fine laceration that went all the way through to reach the vascular plane and the IVC, partly with the skeletonization of the portal vein. And these were the pictures at follow-up. Again, you can delineate the injury really well together with the vessels. Another similar example, another 2-year-old hit by a car, very similar really. Again, some skeletonization here of the IVC, and on this video you will see a follow-up. We could easily see the injury healing, and with a little bit of hyperemia initially, but then as we moved on, there was no further injury, and this was healing perfectly. But you can see all sorts of injuries really well. These are a couple of examples of intrahepatic hematomas that you may want to delineate best with CEUS. Again, especially if you want to look for any active extravasation of contrast. This is a slightly different example. This is a teenager who had a penetrating injury to the right kidney. This was the CT scan at presentation. And this to show you a few months down the line, he came back with this picture where there was some scarring of the kidney. And again, this was really well shown on the contrast and ultrasound as a wedge area of infarcted kidney, which was non-perfused. And this was also proven on the nuclear medicine study. So even long-term follow-up, it is a tool that you can use to further delineate the amount of injury, and in this case of residual long-term injury. This is an example of a small boy who came in after an accident where a huge heavy dumbbell fell on his abdomen. He came with what was thought a transected left renal artery on the CT scan, but there was a question whether the kidney was still perfused. And after giving a little bit of contrast, in a matter of few seconds, you can see that there is complete lack of enhancement of the cortex, indicating acute cortical necrosis, whereas the medulla had preserved contrast enhancement. Pancreatic injuries, we rarely really see them on CEUS because we don't really need to follow them up with contrast, because more often than not, they're quite easy to see even on film mode, and if they've had a pancreatic injury, they would have had an initial CT scan regardless, because whenever we suspect that, we still look for any duodenal injury, which you can't really appreciate well on the CEUS. But this is to show you an example again where you can see the fracture plane very easily as lack of enhancement on the CEUS. Adrenal trauma, it rarely occurs in isolation. So you can see it normally together with other solid visceral injury. But again, this may be useful, not so much to delineate the injury as such, but in those cases where you are wondering whether you're actually dealing with an incidental adrenal mass, or whether this is a part of the traumatic injury, you just inject a little bit of contrast. Again, this will show a hematoma of the adrenal gland, will show a complete lack of enhancement, and then you can be absolutely sure that you're not dealing with an incidental adrenal mass. But as I said, where we use it more in our institution is actually for follow-ups, and you can do it to just make sure that patients who are treated conservatively, they can be discharged safely. And as I said, for liver injuries, we tend to do it on day 5, but for splenic and renal injuries, slightly later. And again, we can avoid repeated radiation exposure in these children. And this is an example of a child who came after having a splenic laceration. After injecting contrast, we could see this nidus of enhancement of following a pseudoaneurysm formation of the splenic artery, which is best seen on this. But even when you do see a large pseudoaneurysm like these ones, which we still tend to embolize, especially when they're large and they're in the liver, and when there might be a biloma as well surrounding them, so they're at higher risk of bleeding, we still embolize these pseudoaneurysms, and you can easily perform a CEUS on table after embolizing them to make sure that the embolization was successful. Again, you'll have a degree of hyperemia surrounding the embolized pseudoaneurysm, but this is really helpful to just establish whether your embolization was completely successful or not. So to conclude, CEUS has been proven to be a very safe and a radiation-free, importantly, imaging modality to investigate trauma in children. We've seen that the performance values are really close to those of CT. We have completely replaced the use of CT in the follow-up of these children in our institution. And more and more, we are using these as a first-line investigation where a CT is not warranted. And this applies to all those cases where the child comes in after a minor fall, say they fell at the playground and they have a little bit of a bruise, but they're not unwell enough to warrant a CT scan. Those are the cases where a B-mode scan may well be normal and as a false negative result. But those are the cases where CEUS is really, really helpful, because you can focus on the organ of interest and you can clearly demonstrate whether or not there is an injury. And if you want to hear some more about this, you can all come to London next year in June when we will be having our CEUS course. And I just want to thank my colleagues and people who work with me on CEUS in pediatrics here at King's. Thank you very much.
Thank you very much, Anna Maria. That was a very elegant presentation showing us some really fantastic examples of using contrast-enhanced ultrasound for many different applications in pediatric trauma. I think what's particularly interesting is the role of using CEUS not only for follow-up as we have traditionally used it, particularly obviating the need for CT, but also in the acute setting, and then also for the more intermediate term follow-up as well, which I think is really, really interesting. We have a couple of questions, so sure. If I could put those two, that would be great. So the first is from Matthias Johansson, who asks, could you give us a bit more of a reiteration regarding the optimal timing for follow-up for particular organs? So, for example, is there a different optimization for follow-up for the spleen compared to the liver or kidneys? Is it related to the trauma grade? And how quickly after trauma would you expect to see pseudoaneurysm formation?
Sure, it's a very good question. Thank you actually for asking. As I said, you have to refrain yourself from scanning them too early. So typically for livers, we scan them around day 5, pretty much on day 5, if not day 6 maximum. For spleens and kidneys, we tend to do it slightly later, as I said, between day 7 and 10. And this is because we've seen they have a tendency to form slightly later, as we've seen in one of the examples on one of the patients who got discharged too early. And there was another bit of the question. So that was in terms of timings. And
is it related to the degree of trauma, or any grade still similar kind of follow-up?
Yes, sure. No, any trauma will deserve a follow-up examination. Obviously, for those with grade 5 or 4, you just have to make sure that when you're scanning them, you can see the integrity of the lesion in both the arterial and venous phases fully. You just have to make sure you can actually see the whole of the extent of the injured parenchyma. But obviously, it's much easier for the lesser grades just because you can see them in one go a little bit easier. For the higher grades, I would just have this thing of just making sure that you see everything in both the arterial and the venous phase, the entire extent of the injury. Yeah.
Great, thank you. We have another question. This is from Peter Belov, who says, thank you. Please, what if we don't have CT in our hospital? Is CEUS or even just ultrasound good enough on its own? Did you compare these two modalities?
Yeah, sure. So I would say that B-mode ultrasound is not good enough, so I would go for CEUS if they can. In terms of CT, I'd be very reluctant to rely on CEUS alone in those polytraumas who come in, because you can't get away without a CT. You need to do a proper CT. You have to look for any, obviously, bony injury, for any hollow viscous injury, so you cannot get away from doing a CT. CEUS is really for those sort of, as we said, minor injuries, intermediate level of worry from the clinical team, where you don't want to send them away without imaging, but ultrasound alone wouldn't be good enough. So for all those cases, yes, CEUS in the first instance. All the other cases, CEUS for the follow-ups, because the CT is still needed at presentation. Yeah.
So it's really on a case-by-case basis, depending on the level of suspicion from the clinical team and the hemodynamic effect on the child, etc., etc.
Absolutely, bearing in mind that, again, if the mechanism of injury is bad enough, like a polytrauma or RTA, I would always do a CT.
Okay, that's great. Can I ask one question myself? So in your presentation, you alluded to the fact that CEUS does fall down slightly compared to CT in some circumstances. Can you elaborate on that? Are there particular themes with regards to where CEUS is perhaps not as well performing as CT?
Yes, sure. Those are the cases where, if you say you find a pancreatic injury on CEUS, I wouldn't be happy with that alone, because often we do see that they are associated with duodenal hematomas, or again, whenever you have a worry about possible hollow viscous injury, then I wouldn't rely on CEUS. And also for the renal injuries, you are also, something that I should have mentioned before as well, you also have to remember that some is not excreted through the collecting system, so you won't be able to pick up accurately an injury to the collecting system of the kidneys. Yeah.
So I think that's a really, really important point, just for everyone to bear in mind.
Absolutely.
To be really clear in everybody's mind that the contrast agents are purely intravascular. They're not excreted in the same way that iodinated contrast or gadolinium is excreted. So as Anna Maria has just said, you cannot evaluate the renal collecting system, any potential renal collecting system trauma. So I think that's a really, really important point.
Yes, absolutely. Yeah.
Thank you.
Thank you.
Thank you very much, Anna Maria. That was excellent.